Hello and welcome to Mental Health Rebellion 101. My name is Hudson Harris. I am joined today by three absolutely incredible people who are going to talk to us about what it takes to create change from a paradigm and from a framework approach. My goal here is to help all of you learn about how you can take these different frameworks out to your communities and to stay out of the guess way as much as possible. John, would you like to introduce yourself?
Sure. My name's John Ohanian. I'm the president and CEO of 211 San Diego. Been 11 years in the spot, and we're excited about some things that we're doing. We incubated a project called the Community Information Exchange. And so basically the best way to describe 211 is you dial 911 for emergencies, you dial 211 for everything else. We're a 24/7 crisis line helping people connect to social service, community programs such as food assistance, housing, and things of that nature. Here, the buzzword in the health community is social determinants of health. That's the world that a lot of our social workers have been doing for many years. One of the things that we found out was when we give out information and hope that people are connecting to these services, we never know necessarily if they connected with those services, if the provider was the right provider for them. And so about 8 years ago, we won an innovation prize for an idea called the Community Information Exchange, a way that we can take that client, and when we make a referral to an organization, we can actually have a closed loop to know that that organization received that client, that they're going to be getting services. And it's also an ecosystem to allow organizations to make referrals to others and keep that client record. It's all about understanding, if you're the person calling in and wanting to get assistance, are we navigating you as a system? Not one organization does it all. We work with about 6,000 programs and services just in San Diego County that are doing this type of work. So we want to make sure that that journey for our client ends up getting them the help they need.
Thank you, John.
Sure.
Kirsten?
I'm Kirsten Carchmer, and I'm the CEO and founder of Brazen. Brazen means to overcome something shameful with swagger. And in the U.S., over 82% of women report every single month that they have significant and life-interrupting menstrual pain or PMS. And that was, as a person who'd been a clinician for almost 20 years, helping over 10,000 women, I was surprised, more than surprised to find that out. And as I started researching that, I started asking women, almost every woman has significant menstrual disease. Why is no one talking about it? How can we possibly be in the middle of a women's movement and no one is talking about our health, about women's health, and more importantly, especially given the context of what we're talking about today, around mental health, because so often women are overdiagnosed with bipolar and depression and prescribed lithium for conditions that are most likely to be related to their menstrual, not most likely, but often related to their menstrual cycle, where pharmaceutical interventions are not necessarily the appropriate intervention. So our technology helps to help women to understand that their menstrual cycles are a reflection of the sum of their habits, and that their menstrual cycles are also predictive of their long-term health. So all the conditions that are related around menstrual disease predict or increase the likelihood of heart disease, diabetes, stroke, and estrogen-dominant cancers. And so our mission is to build technology and products to help women to understand that ecosystem and then have agency, right, to have control of their life and their future outcomes.
Thank you. Stephanie?
Hello, everyone. My name is Stephanie Morgan. I am a design researcher at the Design Institute for Health at Dell Medical School. We are a kind of joint institute collaboration between UT Austin's College of Fine Arts as well as Dell Medical School. And I'm here today to share a variety of work we've done to look at how we can use design as a tool to create systemic change in healthcare. And when I say design, I mean everything from more traditional industrial product design, digital design, as well as looking at more of a systemic level, service design, how can we actually get new protocols, procedures, care models, business models, and lastly, more of the communication design. So how are we actually going to be able to disseminate this information and get people aligned on a new pathway forward? And specifically here, I might be talking about some of the work we've been doing with the Austin State Hospital redesign, which is the inpatient psychiatric hospital here that serves about 38 counties for adults in Central Texas.
Wonderful. Thank you all for being here today. Just to kind of kick us off, you each gave very good introductions of your organizations. What I'd like to start this with is, for each of you, and let's start with you, Stephanie, what's your mission, the framework of approach that you're going after with redesigning the hospital system, with reimagining care delivery models? I will say I took a tour of the Dell, of the Design Institute, and their clinic space has no waiting rooms, and it's absolutely incredible. So those types of things are really kind of pushing pushing things forward, disrupting a lot. But if you could kind of sum up your mission and what you guys are really trying to achieve.
Yeah, we're actually, it's pretty simple. I think we're looking to rethink everything when it comes to healthcare. So you can take a building, for example, and say, let's just design the spaces in a new way that we think might be provocative. And that's part of, I think, the way to address the solution. There also is the idea of we're going to need to train people in a different way. We're going to need to hire people who have a different mindset about approaching healthcare, which is a legacy system that we've kind of practiced in the same way for years and years and years. We're going to need to look at the financial component to all of this. Money is a big driver in healthcare. How can we be funneling that money into different ways? How should we be setting up spaces such that patients will walk in and feel a sense of calm as opposed to the fear that's so commonly associated with healthcare? So I think it's taking that systemic approach. It's understanding all of those pieces and being able to, both from a skill set as well as an organizational mindset, being able to execute on all of those as well to deliver the holistic solution.
Perfect. Kirsten, I love your definition of Brazen, and I love that that's what you named your company, because I think it's absolutely perfect for the space that you're living in and for what you're going for. What would be your dream or your mission for what you want to bring to the women of the United States, but ideally the women of the world, especially in light of us working with the Sustainable Development Goals?
So thanks about the name, because I really spent a lot of time trying to figure that out. So our mission, not only for women in the U.S., but for women globally, is to give them the tools and resources to help them to liberate themselves from their menstrual cycles, from their health problems, and whatever it is that restrains them. And so we feel like the first place to help women to have agency in any part of their life is through education. So many women have no idea how their bodies even work, much less how to understand that all of the problems that are happening around their reproductive system are not only, they're more than just a nuisance. Actually, they're prognostic in nature. And so our mission is essentially to end menstrual misery.
Can you expand a little bit on the agency concept? Because you've mentioned that a couple times, but I think that's a pretty important part of what you're doing.
Well, I think that, most of the women who have some form of menstrual disease, so, PMS, cramping, endometriosis, polycystic ovarian syndrome, even infertility, I think that women feel very victimized by their bodies. Right, and they feel like there are not a lot of choices. You can either have surgery or you can take pharmaceuticals. And most of the women that we talk to about their menstrual cycles, they say, well, this is just the way it is. I always joke, like I'm a wannabe stand-up comedian, and I always joke and say, like, if we went into Congress tomorrow and we, had some devices that would simulate menstrual cramps, but on men's testicles, and we passed out like cupcakes and wine for everybody, and we said, we'll see you tomorrow, ladies. We'll hear some Tylenol. If we came back the next day, the men would say, that's never happening again. Mm-hmm. But we've been conditioned for so many generations that this is normal, this is how it is. We can't have agency to improve our health, the health of our offspring, and the health of our future if we don't even understand that that's a problem that's important and relevant diagnostic, but also that is absolutely addressable with tools that are practically free.
That's wonderful. So in the interest of full disclosure, I live in San Diego. I'm also a big fan of 211 San Diego. John, can you explain a little bit, one of the things that really struck me as novel and innovative about what you did with the CIE was how not only you connecting people, but also how you created risk taxonomies and scores of how people are rated so that you can kind of build the support that they need. Can you talk a little bit about that?
Sure. So there's a term called collective impact, and really the term collective impact means how do you change a community? How do you take goals that are bigger than one organization, but organizations and community-wide? And so in San Diego, we have Live Well San Diego. It's a strategy that the County of San Diego set out to basically improve health in our community throughout our entire community. And a part of that, one of the tenets is, we need to build trust, we need to build networks with other organizations. 211, while I'm proud of the work that we do, we're nothing without the community partners that actually deliver the services. And really, we try to just be a good go-between clients that are, don't have apps on their phone that find social services as quickly as, you can find Uber or Yelp. And so in social services, because it's so complex, not only do they need to find that right spot, but they need help when some need is not being met there. And so for us, it was grabbing a network of partners. Right now, we're proud to have, out of 1,200 agencies, 56 early adopters to the CIE that are trust network partners, and we call them trust network partners. But each organization evaluates their clients differently. So someone might evaluate someone's housing risk differently than agency A, agency B. So we came up with a risk rating scale to assess clients that all agencies would use, and we developed it with them to figure out what would work. And then agencies can share clients, share outcomes, communicate in an easier fashion. So a number of those things that take place, and when people want to replicate what we do, we first tell them, don't do it the way we did it. We've been on this for 8 years, and we're having to retool things that we set up. But it's really make sure that you have a good network and a good community ready to do these bigger vision projects, and then you can get started on the technology and all the other things to make it happen.
Stephanie, the organization you're working with is not just redesigning the state hospital system. It's completely changing the face of healthcare, cardiology, mental health care from the ground up. What are some of the barriers? What are some of the hurdles that you guys have found that were a surprise over the past year or two, and kind of building out something that is disrupting? Disruption is kind of a understatement for what the work you guys are doing.
Well, thank you. I would say for me, when we look at design, and it's been growing in popularity, especially human-centered design processes, practices, and it's kind of mapped out as this nice linear process that you can go and learn and hopefully implement. And I think for me at least, it's understanding that process end to end can happen and you can implement things, but not only does there need to be evaluation continually and follow through and iteration to improve ideas, but also there's a huge person component in terms of seeing something through and seeing it through to success. So that accountability angle. So how can we actually design for accountability? How can we design for someone to be like, I'm responsible for this. If this does not get acted out in the way that it was intended, I personally will do something to change that. I think when we look at physical and digital design, you can create something, but creating behaviors in people is probably one of the more challenging things. So when you look to disrupt a system, changing the behavior from both the patients themselves, but the providers as well, has been, I think, probably one of the biggest areas we're still looking to improve on.
Kirsten, that strikes me as something that might be something that you deal with on a routine basis, both from the women that you work with and then the populations you work with. But that changing of behaviors is something that has to be pretty ingrained deep in what you do. How do you tackle that issue?
Well, I think there's a few critical parts that what we're doing might be interesting. I was a reproductive acupuncturist for 20 years, right? And so I had been spending time with women for almost a year trying to help them, in analog to modify their behavior. And what I realized is that there is an order of operation for behavior change that most people are not talking about. And so, for example, if you're trying to help a woman or someone to change their dietary habits. This is really, we know for all of us, right, who's not in the perfect health that we want to be, that's really hard to do. But if you look at the entire ecosystem, which is what we try to do at Brazen, as opposed to identifying this problem or this problem, like what does the entire ecosystem look like? And if you see, actually this person only sleeps 5 hours a night. First of all, society rewards that, like, oh, you're so tough, especially, we're doing it all. But also, when you're exhausted, you're producing more adrenaline, so you're then producing more cortisol, which actually makes you hold on to calories more, which makes you crave carbohydrates more, which makes you less likely to be able to resist eating foods that are not ideal for you. So when we're working around behavior change, the first step is to really identify, okay, what's the whole ecosystem, and what's the order of operations about how we're going to fix this, and then we start with one thing. And we say, okay, well, the first thing this person has to do to actually have a behavior change that's not even related to the most obvious behavior change is they have to X. Like, we have to help them to sleep. And then we have to diagnose for that. So why isn't this person sleeping? Is it because they're having too much caffeine? Is it because they need mental health? Is it because whatever? And then you have to address those problems. So I think that the secret for great behavior change is better diagnostics in helping people make a plan that makes sense.
Sleep is really important too. Mine is because of my 2 children, but it's one of those things where you find those small micro changes at a root level really have an exponential impact as they go up. John, given the amount of work that you do with social service agencies, and given that a lot of social service agencies haven't really gotten on the tech revolution, how do you work to get buy-in from those organizations to, similar to what Stephanie was describing, but really shift a lot of what they do to go through technology?
Well, I guess that's one of the lessons learned that I would say in visiting your center today, is kind of furthers it that we need to be building systems around the users. And I know that everyone talks about it. It's not a new concept. It's actually the way it's supposed to be done. But when you're working with social service organizations that are, I would say, all of us, and I would include the 2-on-1 system in that, you're talking 20 years behind the times. It's not a technology that's going to provide the help. It already exists. It's getting this base, this network of social service providers to actually see it as a need. It may impact their ability that one day. It may add a few more minutes to them when they're helping a client out. But the big impact of having that individual record be something that can be used by all organizations over time. And also, I think people don't see it as their own information. We want our clients to be empowered with their own information so that when they walk into a support services or when they're with their doctor, they can really show, here's my situation, here's where I currently am, to understand how to best get the help. And I know, we're talking a lot about mental health. One of the things we've noticed from not having that best coordinated system in our communities is we create that. Clients that have to call numbers of places to get the help. They have to take 3 different buses to get to a center to get help versus the old model of a doctor makes house calls, looks around the house and says, you know what, this person might need some other things. We've gone so far to the other side that we are creating a lot of that tension with our clients as well.
Stephanie, kind of following up on that, can you describe kind of the patient experience at the Design Institute in your clinic of how you've operationalized what John is talking about as far as bringing things to the client or making that as easy as possible? Because that's a pretty amazing way that you're doing that.
Yeah, so to start with our UT Health Austin clinics that we worked on redesigning, when you walk in, you're greeted by a concierge staff, so it's pretty much a one-on-one interaction, and all of the billing paperwork is done there on an iPad with assistance and interpretation if needed for language. You're then invited to make yourself comfortable anywhere in the hallway. There is no formal waiting room. And ideally, when the room is ready, which usually is pretty quickly, the patient is escorted to that space. They're allowed to sit in there, make it their own, put their belongings in a cabinet, adjust the lighting as needed. There's a bunch of wayfinding and signage to help them with that. In terms of understanding that. And we do practice an integrated practice unit model, which means essentially when you're coming in for a visit, for example, for knee pain, instead of going to a doctor and getting a referral and then getting a referral to PT and a referral for this, all of those providers are in-house and ready to care for you. So you might see upwards of 3, 4, 5 providers in one visit, so they can be a bit longer, probably around like 2 hours or so for something like that. But ideally, you should walk away with your nutrition weight loss plan, your cognitive therapies you're going to be using to practice more mindfulness when it comes to pain control, your PT exercises, any sort of joint evaluation from the doctors. So we're really hoping that in that one visit, the experience of the patient will also be improved, but the outcomes will be simultaneously improved as well.
So, kind of an underlying theme throughout all of this is really the concept around reducing both the burden of coordination of care, but then I think almost more importantly, it's reducing the barriers to care. And I think that's something that a lot of people, I think, struggle with understanding is that whether you're working, in a clinic situation or a community-based situation or a hospital, every step creates a barrier and you lose people. If you're working, with a challenging mental health condition, getting on a bus to go get your medicine is something that's a real challenge. Kirsten, how do you see Brazen Health helping reduce some of the barriers to care? So part of that agency discussion again, so taking control of who they are, but then how would you like to be able to have Brazen Health make it easier for people to get the care that they need and get the information that they need?
Well, this is a big mission for us. We've talked to thousands of OB-GYNs across the country, and one of the messages that we get so often is that, to really deliver excellent women's health care, women need a multidisciplinary team. But what sounds like what you guys are building is really exactly that, which is really on the cutting edge of everything that is really valuable to all of healthcare. And we really listened to that, and we thought, well, can we, this is the kind of care that we are providing in our clinical experience, but can we use technology to be able to deliver, to pick up some of the slack where in areas where people don't have access to this kind of care, can we use technology to, one, be able to sort of diagnose the needs of that patient, right? And then be able to deliver exactly what that person needs at that particular piece of time. Now, is that as good as actually getting to be with a human? Never. But can we, even if we can meet people 50% better than what we're currently do, we think that's worth doing. And in some situations, like in our first iteration of this was only with fertility patients, and in the pilot that we built, the success rates were actually better than even in my clinic. So we took humans out and we actually took acupuncture out, but because the algorithm is not subjective, right? So it's not distracted by anything. It's really saying yes or no to the decision tree. It was able to curate better interventions and then use technology to get feedback on the behaviors of the individual and keep modifying using machine learning to modify the interventions. So the success, the fertility outcome, the pregnancy results were even better than they were in a clinical setting.
That's amazing. What kind of data is that algorithm taking in? Like, what are its information sources?
So it's taking in information about their basal temperatures, about their lifestyle behaviors around sleep, around food, around water consumption, around vegetable consumption, around stress, and then signs and symptoms, and then every single parameter of their menstrual cycle.
That's amazing. John, what are some of as we look forward, everything that's been accomplished at San Diego 211 and the community information exchange, what are some risks that you want to take over the next couple of years? What are the things that you're wanting to push the boundaries of where you are now to where you want to go?
Well, I was kind of just inspired with what you just said, and it made me think of a number that always shocks me, is that we get over 1,500 calls in a day. 70% of our clients say that they have no social support system. And so when I think about how the experience needs to be once we actually get that individual to a provider, having that provider experience be what we all want for our families. So I think the biggest challenge is this work takes time. We're in a situation where we're constantly having to fundraise for the work that we're doing, even though we know that there's value. We know that the value work that we're doing with coordinating someone's social services is a value to health plans. We've done research on our outcomes, seeing a reduction in EMS transports. We know we save government and hospitals money. We have a 70% reduction in individuals falling from housing into homelessness when they're coordinated, because we're giving them that support system that doesn't exist. And so what I want to see is more of a push towards how do we figure out a way that feeling of supporting people is supported by the technology. That technology doesn't trump that, but it actually supports it.
And if I remember correctly, you guys have a program where you work with post-discharge high utilizers from the emergency department that you've had some pretty remarkable results with.
Yeah, I think it comes back to the same thing. If you check in on people, there's a reason why people aren't accessing services. They may call one day or they may have a need, but guess what? There's other things that are more stressing in their lives. They're taking care of their families, and so they don't always make that contact. And so I think as providers, it's not good enough to give them the information, but know that a lot of these individuals need other types of care and help. We've shown individuals that were recurring, 30% of them were coming back to the emergency room. Just by one phone call every couple weeks, we reduced it to about 9%. And that could have been just a phone call saying, checking in, did you need anything else? And so I think if we get a way to do that a little bit more, and again, it's not just us as an organization, but we want to, our whole point of this tool is that it serves, if both of you are working with the same client, you now have a tool to actually see that you are working with that client, and hey, you know what, I'm going to call and check on Kirsten's client for her and let her know what's going on. And now we have a little bit more of a community helping these individuals versus them being bounced around our system.
So that's actually one of my most favorite aspects of the CIE. Can you talk a little bit about that care team aspect, about how providers can kind of work together on the same person?
Yeah, I mean, it's a work group, right? I mean, it's at the basic fundamental level, and some people don't like me saying it because it needs to sound more complicated than that, but all we're talking about is a shared case management system among providers, and regardless of where they work. And so in its simplicity, that's what it's about. The nice part is we don't require people to change their systems. It interacts with their existing one. But then when you look up a client, you'll know where else they're getting services at, what other providers, and you'd be amazed at the number of organizations we work with saying, we knew that they were going maybe over here, but now we actually know the caseworker to pick up the phone and call. We've put alerts so that when someone gets picked up, a lot of individuals with mental health challenges are getting picked up by police, they're taken to jail. We now have an alert that hits if they're being arrested. the jail alert hits the system, the case manager is notified, the case manager can go deal with it. I mean, public safety, if you look around the country, we know as public safety doesn't want to spend money locking up people and spending a lot of time with individuals that really are going to be released because they're not doing criminal activity. They have mental health challenges. And so we can reduce that burden. I come back to the dignity part. It's what we're supposed to be doing. And so I think a lot of these things are being done. Now that our communities are so disjointed, we need the systems to kind of bring a little uniformity there.
Stephanie, I'd ask the same question of you, but with kind of a lens that what you guys are building at the Design Institute is not just here's a project plan of what we want to do and go. The human-centered design experience really creates, longitudinal maps that are constantly growing. Where are the risks that you're wanting to take? You mentioned earlier the innovation clinical room. What are the things that you're wanting to do? What are the things that you're going to force you to take risks and make those kind of hard decisions?
I don't know if this is answering the question, but I would say it's taking that risk. I think there is a lot of talk and there's a lot of ideas, and we were just talking about this actually at our Monday morning meeting with our team, and how a lot of conversations happen where individuals talk about like the principles you should be designing for, how to go about doing things, and methods and processes. But at the end of the day, are we actually doing? Are we learning? Are we iterating where we're wrong and knowing that we will fail? I think it's not coming in with any preconceived notion or thinking you're going to have the one-size-fits-all nail on the head that first try. You're going to fail. And as long as you are open to that and you have an organization that supports that process, I think that's where the room for opportunity really lies.
So going back to your accountability comment, from earlier.
Mm-hmm.
So how are you bridging that? I mean, what is that? I think everybody here has worked with medical professionals that at times were difficult, perhaps, to work with. Like, how are you actually doing that in real life? Like, how are you bridging the innovation to action step?
Yeah, so for example, we had some great praise about the clinical spaces that we have opened and been operating for about a year and a half now, and we got feedback from our providers about what they didn't like about that within weeks of it opening. Things that ranged from the chairs are uncomfortable to sit in for certain conversations I have with patients. The rooms still feel a bit cold with the coloring. We're having issues with some sound with difficult conversations. So we received a lot of feedback about our design, and I guess as designers we could have made the call of, well, we did it, it's done, we think it's perfect, bye. But instead as a matter of a couple months ago, we did 2 mock-ups of different styles of rooms with iterations on some noise, some different warmth kind of aesthetics and detailing to help try and bridge that gap of what the providers were voicing. We had them come through and look at it and take surveys and give us feedback on it in service of seeing how we can continually improve. So I think it's never looking at something as a done deal, and always as just a learning lab and the ability to prototype things and try them out and learn from them and be open to the feedback and receptive to it.
Kirsten, can you talk a little bit about your iterative development, some with the breadth of experience that you have and the number of women that you've helped, and then even moving into the space that you are now with the tech that you're bringing? How do you iterate? How do you design, with some of the same kind of ideas in mind, that we want to be able to fail fast and fail forward? So how do you do that?
Well, I want to dovetail off what you were saying around failing. I think that a piece of advice that I had from a mentor was really critical about 4 years ago. He said to me, he goes, "I don't think you're playing a big enough game." I said, "What are you talking about? I'm like breaking every rule here." He goes, "No way." He goes, "You're not failing enough." And I said, "I don't know, this didn't work and that." He goes, No. He goes, "You want to really break something, you need to set a goal to fail 50% of the time." He's like, only until you really aspire to play so big that half of the things that you try don't work, that you will discover something that you never thought possible before. And so that really gave me a lot of freedom. This person happened to be on my board also, so a lot of...
That's fortunate to do a board
a lot
member
of
that
support,
supports that.
right?
That's,
for the board
that's really
saying,
rare.
Like, we have invested in something big here, and we want to see if you can crack it open. And so that kind of support, like you're saying, the institutional support is really critical to that. I mean, I think that the innovation when you're building technology and you have tens of thousands of users using your system, it actually gives you very fast feedback. And, because women are for the most part that we've been working with, have had, a lot of interest in helping us to succeed. They want us to win too. So getting users to give us great feedback, to do interviews, has been incredibly useful for us. We're basically I know what's possible around changing signs, symptoms, outcomes in an analog system. So that sort of was our benchmark that we were working against. Can we do it more effectively with less friction? How can, our goal is basically how can we minimize the requests, the asks that we make of users to have the maximum outcome in their health changes? So what's the least that we can get them to do where after 3 or 6 or 9 months, and for the least amount of money, right? Really our mission is, partly to really democratize access to women's health. So that's...
I want your funder because I'm going into my funder on Tuesday and I was like, okay, well, we failed about 4 times over the last 8 years. Really? I mean, it's serious. And to have the commitment from the funders to hit that 50 mark, I really do feel like a lot of the work that we do needs to be a little bit riskier in the sense of we're not set, right? We don't have it right now. And if we could take a team and say, you know what, your job is to just continue coming up with things, and we're not going to judge you on how many successes you have, really that work's happening. And I mean it kind of seriously. It is going to come out of my mouth on Tuesday because I feel like that's what the funding community, some of these projects, if they were easy, they would be done by now.
Of course.
And so I think as a community, we need to be a little bit more bold we need to take examples outside of our country, which is what the health paradox is all about. This 80% of our healthcare is not health. And what are they doing in other countries, and try to learn from that as well.
Sure. And I think that in terms from, dealing with investors around it, asking them, what do you really want from us? What is the outcome that let's have a really honest conversation about what would in 3 to 5 years, what would be the outcome that would have blown your expectations out of the water? Mm-hmm. And if they're like, well, we want, X, Y, Z, P, D, Q, you're like, great, we're going to have to take some risk. We're going to have to fail to get there because nobody playing safe gets to that kind of outcome. And then you can force them.
I love it. I'm using all this on Tuesday. I'm so excited.
I'll come and be your CIA person.
Thank you.
Stephanie, your investors, such as they are a little different than anybody else's here. Can you describe how that creates a mandate for the Design Institute that's totally different than, frankly, anywhere else I've heard of?
Yes, Dell Medical School is funded by the community. We are funded by an increase in property tax. So if you own property here, you are helping fund Dell Medical School.
Wait, so a community actually voted to help people with healthcare by raising property taxes?
Believe it or not, yes. And specifically, which is even, I think, more impactful, in the interest of providing services and care for the historically underserved. So when you have that mindset and that support from the community and the money supporting it, a large portion of our work also is focused on not just our clinics and the in-house spaces that we have, but getting at a lot of the conversation that we're having around social determinants, community health, aspects like that. So a lot of the funding that we use for that comes from that, as well as we do have some grants and whatnot more traditionally. And so we're able to augment and support a lot of those engagements too, which is awesome. So something like a 40K effort might be double that, and we're able to invest our services accordingly.
And I know right now the Texas legislature is having hearings on your, grand master plan around how to redesign the state hospital system. So was the goal more beds, more bigger hospital, et cetera, or what did you aim for?
We had 3 recommendations that ranged in terms of what you could do with the actual building and number of beds, as well as how you could potentially push the model of care, the actual operational procedures, as well as policy, depending on how what option you wanted to select per se. So the first one is looking at, yes, I think about a 240 bed building. Second option looks at maybe a slightly smaller main building, but then building in about a 48 bed residential center. So acknowledging that not every person who needs inpatient care needs that more intensive inpatient psychiatric care, but there might be some more gray areas of how we can be providing care to that individual in different formats than is traditionally used. And then the last one would be just looking at more of a traditional understanding of, well, we need to provide more care, so we will just give a huge hospital with a ton of beds, and that is how we will continue to provide mental health services.
So call your state senator, vote to support, tell them they should support option that the Design Institute came up with. John, I didn't forget about you because I want to come back to this. How does 211 handle innovation internally? How do you guys try and drive new models and new development that supports kind of this idea that we want to be able to fail fast in a safe environment and yet continue to grow and push the boundaries of the care that's being provided?
Well, we learn from our clients and we learn from our providers. When you get that many calls in a day and you're able to understand, are people able to connect or are they not able to connect? They need affordable housing, but it's a 6-year waiting list. Okay, guess what? What's option B? What's option C? So we want to do a better job. I think that we have a lot of data. We're accumulating data. I don't know how well we're doing on the mining side to actually inform how better we can change the client experience. And then on the provider side, watching. I mean, we've dropped this community information exchange out there. We've done, I think, a lot of messaging to get people to buy into the vision of it. And now we have care managers and case managers throughout the community that are starting to use it. But the adoption's slow. It's tough work. So we need to learn faster. We need to be able to do a release, fail it, start a new one. So a lot of this discussion, a lot that's been happening over the last few months for me personally, is looking and saying, maybe we're not doing as well as we need to. What do we need to do differently? We released a toolkit because one of the things we want to see is more of this work happening throughout the country. So we released a toolkit a few months ago. We're doing webinars basically sharing our story, but we're trying not to say it in a sense of this is how you do it. It's more this is what we've done. Our community is very different than others. And we have a summit at the end of April, and that's my shameless plug, because if there's people that are interested, we want those individuals that are doing this work to come in as well so that we can all kind of figure this out. It's tough work.
The summit's really amazing. You should check it out. You can find links to it on 211sandiego.org. Kirsten, in a similar vein, how do people find you, or how do you find your clients? The work you're doing is incredible, but where are you getting your people? How are you helping them?
Mostly online through social media. I mean, I have a book coming out in August called Seeing Red, and Seeing Red is about, one, seeing the menstrual cycle is more than a curse, right, as the most valuable barometer of women's overall health, but also to see that that women's health is really in trouble. That the majority of women have some kind of menstrual disease, and only 4% of research dollars are being allocated specifically for women's health research. And so all the brouhaha around the book has also helped to attract, customers and I hate the word users, women who use our products and benefit from it, and word of mouth, just through internal communities and things like that. As time progresses, we'll build out those opportunities more and more.
I think the next time I name something, I'm going to call you first because I like your naming conventions. As we start to wrap up, I want to give each of you an opportunity to maybe share a nugget or two for people here, because I find that the small ball approach to community change, healthcare change, women's health change, starts with one ball forward each day. And it's something that I really enjoy about the work that I do is that let's move each ball forward a tiny little bit. So, John, I'll start with you. What's the small ball forward that people can take into their community to start to move this forward, whether it's a community information exchange type model or connecting social service providers together? What's your small ball suggestion?
Well, community organizing is powerful. I think that when 211 was started 15 years ago, we had a coalition of about 120 nonprofits and different organizations that we people before me went to the community and said, we're thinking about this idea, what do you think? And built community support, because once we launched, we really needed them to be a part of it because we didn't exist without them. And I think that's the same thing with a lot of these projects is you may not be the lead, we may not be the lead in a few years, but to have that entity exist or to have that kind of coalition happening, do you have a common goal that you're all trying to work towards? And then if you can identify a goal and you've got a team, then you have the makings for whatever comes next.
That's wonderful. Kirsten?
I think that for anything, right, for change to happen, education is really critical. And in women's health, like I mentioned before, the first step for us is to acknowledge that what's happening in women's periods is not normal. Right? Just because 80% of us are sick every single month doesn't mean it's normal. It just means that it's common and that it's changeable. And so my request, if people want to do the local thing to do, is to go on social media and make some kind of comment that PMS and cramping aren't normal. Right? You can ending menstrual misery is the first step to female empowerment. Right? Because we can't really win take any place in society when we're not first taking care of ourselves, like putting the oxygen in ourselves.
That's actually something that I've seen a lot. Is I'm not really big in social media, but as I've started to become more and more in positions like this to try and help spread the messages that you guys bring, I found that the destigmatization can be as simple as a meme. It can be as simple as a post about having a bad day, or that you're struggling with, your own anxiety, your own depression, and that's really powerful, because I think there's power in sharing. It creates a common burden, and it eases it just a little bit each time.
It's interesting that you say that, because I have a 13-year-old daughter, and while with my 15-year-old son, we sort of talk about everything. There's really nothing it's not on the table for us. And but with my 13-year-old daughter, she doesn't want to talk about any of this. She's quite mortified. And so I kept thinking, like, well, how can I talk to her? How can I educate her about the things that I think are important about being a woman without mortifying her? So I started sending her memes, right? And so we didn't have to have a conversation about it. She doesn't want to have a conversation about it. And so what she would do when I would try to talk about it is she would get on her phone. And so I was like, well, if you're going to go on your phone, I'm going to meet you on your phone with humor and see if I can start, infiltrating that way. And it's been really effective. So you're right. Humor can be a really powerful way to destigmatize any difficult conversation.
Can you share some of those later? Or
Yeah.
That'd be wonderful.
Oh,
Thank you.
yeah.
Yes, please do. Stephanie, what's your small ball takeaway?
My small ball that you could theoretically do before end of day today would be to sign up for a mental health first aid course. I don't know if they have a formal certification yet, but a course. Educate yourself, understand what you can do when someone is perhaps on the brink of crisis or in crisis. We have no problem as a society getting CPR certified. Some jobs require it. Someone drops to the ground. Ideally, someone in this room should be able to help. And it's not the same for mental health. So just take that step forward, become a bit more educated, a bit more informed in a way that you can hopefully help someone in your community.
Wonderful. Thank all of you for coming today. This was absolutely wonderful. I hope it's the first of many in the Mental Health Rebellion. Thank you all for watching and for attending. Be the change you want to see in the world. Thank you.